Good morning, everyone. My name is Laura. I'm a Darrawal woman from the Lapurus Aboriginal community of Botany Bay. It's my pleasure to be here to welcome you all to the 2020 NDARC Annual Research Symposium. I'd like to say a special welcome to our overseas guests. Welcome to country is a modern interpretation of seeking and receiving permission to visit areas beyond our traditional lands. It is a ceremony recognising the cultural and spiritual connection to country. It allows us to pay respect to our elders, past and present, and reaffirm an ongoing relationship to the land. It also allows us to reflect on our history and build a vision for a prosperous and reconciled future. Aboriginal people have cared for the land and waters throughout our country in a sustainable framework for the purpose of food and water and resources, and have a close connection to our environment. On behalf of the Lapurus Local Aboriginal Land Council, my ancestors and people, I welcome you all here today and hope you have a great day and enjoy your symposium. Thank you and welcome.
Good morning, everyone. Morning, everyone. Thank you for joining us for the session 4 of the NDARC 2020 Symposium, this one focusing on illicit drugs, research and clinical responses. My name is Dr. Fadil Petich, and I'm the Manager of Strategic Research and Evaluation at the Centre for Alcohol and Other Drugs at the New South Wales Ministry of Health. Just very briefly to acknowledge the traditional custodians of the land on which I am today, which is the Gamaragal people. As I mentioned, this is session 4, and thank you to all those who watched it, been involved in the past 3 sessions. The program for today is as follows. We have 2 presentations which will run for 10 to 15 minutes. We'll have a short 5 to 10 minute Q&A, allowing you to ask your questions of the presenters. We then have 7 featured poster presentations, followed by 2 presentations for 10 minutes each, and then a 10-minute Q&A following that. Michael Farrell will then announce the winners of the poster exhibition and close off NDARC Symposium for 2020. With the Q&A, please use the put all questions in the Q&A function at the bottom of the webinar rather than the chat function, please. All of the posters for this year can be viewed on the NDARC website. We also have a networking register online, again available on the annual symposium section of the NDARC website. An option on this register is to post any questions that you might have from the presentations today, or indeed from previous presentations and sessions, if those questions haven't been answered in today's sessions, and those will be attended to. You'll also have been sent links to all this information via email. All recordings of past sessions and this session later today can be found on the NDARC website under the Annual Symposium tab. To introduce the first speaker for today is Dr. James Bell. Dr. James Bell is a physician who has worked in addiction medicine in the UK and Australia. He developed training programs for doctors in Australia and the UK. He was a leading figure in establishing the chapter of addiction medicine and having addiction medicine recognised as a specialty in Australia. His major research interest is the treatment of addictive disorders, and he has published extensively on treatment of opioid dependence. His presentation today is entitled Mind the Gap Between Research and Clinical Outcomes. James, please present.
Thanks, Fedor, and good morning, ladies and gentlemen. Now, this is a strange experience. Next slide, please. I first should comment that the basis of this talk is that I've had the privilege to work as a clinician, a practitioner, and a researcher over the last 3 decades. And it's a pleasure to speak at this annual NDARC Symposium. I can remember NDARC back in the 90s when we were a group of young people excited about the prospects for the future. It was a while back. I should acknowledge, next slide, I should acknowledge that the potential biases in my presentation. I, over the years, have consulted with many drug companies. In the last 5 years, I did receive some speaker fees from Reckitt Benckiser, and I'm currently employed by Uniting New South Wales in preparing a trial of injectable opioid treatment. Next slide, please. Now, I'm not wanting to challenge the importance of high-level evidence, the evidence from clinical trials, but I'm much more interested in what works in practice. And there's plenty of evidence, the most recent of which was a nice study from Wakeman in 2020, a huge study of 41,000 individuals, basically in multiple modalities of treatment, but the only treatment which was associated with a reduced risk of death in the 3-month and 12-month follow-up were buprenorphine or methadone, consistent with high-level evidence for the effectiveness of these, consistent also with Australian studies back in ATOS in 2007, which certainly looked at participation in treatment and again showed the much stronger holding power of methadone and buprenorphine. Next slide, please. And the problem with this sort of study is that not all opioid agonists are equal. And what we actually have now are 4 modalities of treatment that are quite distinct, not just distinct medications, but I think distinct modalities of treatment. Supervised oral methadone, unsupervised buccal buprenorphine, buprenorphine depot, which is the new kid on the block, and of course, still ticking away in the background, injectable treatment with either heroin or hydromorphone, highly supervised. And these treatments have in common that they are pharmacotherapies, but they have very different mechanisms of action and different clinical implications. That's what I want to talk about today. Next slide, please. Now, just to go back to very basic things, which I find I have to keep reminding myself of, the pharmacological basis of treating people with opiate agonists. First and foremost, to abolish withdrawal during the 24 hours between doses, or the week between doses, or the month between doses. Secondly, to attenuate the reinforcing effect of injected opioids. And thirdly, to hold people in treatment. Next slide, please. Minimizing withdrawal has been known for 40 years. And because it seems clear, if you trust the experiments with laboratory rats, that the primary driver of dependent drug use is avoidance of withdrawal, using to feel normal. And what's been clear for decades is that if you have rapid methadone metabolism, rapid clearance of methadone, you experience more withdrawal. And that is not helped by increasing the dose of methadone, because the gap between the peak blood level and the trough blood level is wide if you're a rapid metabolizer, and the result is the experience of withdrawal symptoms. And failure to suppress withdrawal is associated with low mood, more drug use, and more dropping out. Nicely demonstrated best by the South Australian group in 1999. The other interesting observation, again, nice piece of Australian research, which is nobody has wanted to replicate, which is that methadone suppresses withdrawal more than buprenorphine. And that was demonstrated in the double-blind, double-dummy study of Matic et al., another NDARC spectacular. And the authors of that paper suggested it was because doses used weren't high enough, but subsequent publications have demonstrated that even on high doses, buprenorphine does not always suppress withdrawal, not as effectively as methadone. Next slide, please. The other critical ingredient is suppressing additional opioid use. Suppressing withdrawal is necessary for good outcomes, but not sufficient, because in fact, for many people, 40 milligrams a day of methadone or 4 milligrams of bup is enough to suppress withdrawal for 24 hours. But at those doses or at even lower doses, people can still get reinforcing effects from injecting opioids. And for many people, that's quite a comfortable arrangement. They can continue to enjoy injecting, but without the desperation that's involved in daily withdrawal. Methadone induces dose-dependent tolerance, making injected opioids less reinforcing. So that is dose-dependent and time-dependent. When people start treatment, they develop tolerance over a period of 2 to 3 weeks. In contrast, buprenorphine attenuates injected opioids by blocking receptor occupancy. And so there is a degree of blockade, not total, from the time of the first dose of buprenorphine. Next slide, please. Then the interesting one, and the one that I mainly want to deal with today. Medication needs to hold people in treatment because there is very consistent evidence that longer treatment is more effective and that relapse after leaving treatment is common. In fact, the rule rather than the exception. It doesn't always happen, but it's alarmingly common, as hence the characterization of a chronic relapsing disorder. And agonist treatment holds people because it is reinforcing. Positive reinforcement because people feel the dose coming on. Spectacularly so with heroin treatment, but also with methadone and less so with buprenorphine. Probably not at all with buprenorphine depot because, of course, it's a pretty constant blood level. The second thing is negative reinforcement. If the dose is missed, the patient starts to feel sick, more so with methadone than with buprenorphine, making it easier to drop out from buprenorphine. Heroin is much more reinforcing, and retention in highly structured methadone treatment, which is very demanding of attendance, it's still around 70% at 12 months. And that is treating people who have been fairly unsuccessfully treated with other medications for the most part. Next slide, please. But there is the downside, which has to be taken into account with all modalities of treatment. And however much people try to rationalize diversion, it is the key risk with opiate agonist treatment. In most methadone overdoses in all jurisdictions which provide methadone are due to diversion of prescribed doses. I had the sad experience of doing a consultancy in Bulgaria in 2010, where after heroin became a problem, the government decided to introduce methadone, but they didn't want to have to pay for it, so it was all to be based on people paying fees. Doctors set up clinics, and the only way the patients could afford to pay the fees was to take half their dose and sell the other half. Takeaways were common, and within a year, methadone was the primary drug on the street, replacing heroin. It was familiar territory because exactly the same thing happened in Western New South Wales in 1993, when I was had started working out there a bit earlier. There is a huge problem when too many take-home doses are given without selection. And buprenorphine has not fared much better. When buprenorphine was freely available on script in France, people felt there was no risk of diversion because you could always go and get it from a doctor at no cost. But in fact, people would take suitcase loads of buprenorphine and sell it in neighbouring countries, and there was an epidemic of buprenorphine abuse in Georgia. So, and the NIDA promoted the development of the buprenorphine naloxone combination, which has had variable reports, some suggesting this does deter diversion and misuse, but actually more recent reports suggest that the street value of the two drugs is much the same, and there is a lot of diversion of buprenorphine naloxone, including injection. Next slide, please. Now, to the key questions about why do people drop out and what holds people in treatment. They drop out because they're ambivalent about being in treatment. They think it helps. They hate being in treatment. A bit like the attitude to heroin, which is that they both love it and hate it. They drop out because things have settled down. If anyone's read the rather good Australian novel Candy, describes a young couple who are addicts. their lives just spiral into despair. They get onto methadone, things pick up, and then there doesn't seem to be any need to be on methadone anymore, so they leave. And that is the story commonly. People also leave because treatment costs a lot of money. Private treatment in New South Wales costs somewhere between $35 and $50 a week, and that is a lot of money. It's irksome, turning up daily. Treatment is often not good, and patients recognise when they're getting shoddy treatment, brief, meaningless consultations, industrialised dispensing operations. They just like liquid handcuffs, and they experience all the same stigma that those of us who work in the field tend to experience, that there's something about drugs that is vaguely disreputable. So above all, for all these reasons, they drop out because they can drop out more easily from buprenorphine than from methadone. Next slide, please. And this raises the question because given that much treatment is cursory, there isn't much structure involved, what will be the implications of depot buprenorphine? We don't need any reminders of the risks of unsupervised opioids, but depot doesn't require daily attendance. The question is structure therapeutic for some people? Next slide, please. And on this question, there is limited evidence. We did a study at Langton in 2007, which showed that there was no difference in outcome between supervised and unsupervised buprenorphine. I'll come back to that in a moment. There's a couple of sort of tangential studies, a study from the States in 2010, which showed that program rules and policies consistently explained and applied improve outcomes, that there is a sense that there is a therapeutic element in a well-run program. And most interestingly, Joe Neal, an excellent researcher from London, did qualitative studies with users, and they understand the benefits of behavioural structure and reported as much. Not direct evidence that treatment without any attendance is better, but suggests there might be something. Next slide, please. I would argue that there is another element of structure which doesn't require daily attendance, which is, and something which I think was particularly relevant, for example, to my comparison study between supervised and unsupervised bup. These were in fact highly structured in the sense that there was a clear rationale for treatment and clear objectives. And there is considerable evidence, some from the opiate agonist field, Gersing's study in 2010, and some from the general principles of psychology from Moose, that these clear explanations and objectives of treatment make treatment more effective. And regular monitoring, feedback and review, which isn't the same as regular attendance for daily dosing, maintains that cognitive structure and focus. And this occurs in clinical trials, but much less so in busy industrialized dispensing operations. Next slide, please. And the big question is, can we deliver depot buprenorphine with that sort of cognitive structure, regular reminders? Will that be sufficient? And what we don't know and what can't be answered by clinical trials is, what will potential patients accept? What will tempt people to come into treatment and stay in treatment? And for how many will treatment be beneficial while they take it? How long will people actually remain? And that's one of the key questions with depot bup that again needs to be answered in observational studies. And every treatment has unintended adverse consequences, or we should assume it does, and we don't really know and can't anticipate what they might be. And for answers to these, we need ongoing observational studies. Thank you very much. And next slide, please. The references are attached there, and thank you for your attendance. End of slide.
Thank you very much, James. I think some thought-provoking questions there for us to think about in the Q&A and the discussions afterwards. For our next talk, I'd like to introduce someone who probably doesn't need any introduction, but I'll do it nevertheless. Professor Michael Farrell, who's been the director of NDARC since 2011. Before that, he was Professor of Addiction Psychiatry at the Institute of Psychiatry at King's College London. Michael is talking to us today about the COLAB study, evaluating outcomes, processes and costs of depot-BUP. Michael, please share your findings with us. Thank you.
Thank you very much, Fadil, and thank you, James, for your presentation. Very interesting. So today I'm talking about community studies of long-acting buprenorphine injection for opioid dependence, and I'm talking about an Indivior-funded clinical implementation study. And I'd like to recognize that we have a wide range of collaborators, both clinical, academic, etc., on this. Basically, to go through the objectives of this study was to document and evaluate the implementation of monthly depot buprenorphine in different community treatment settings, and to examine client outcomes, including impacts on treatment engagement, retention, and patient satisfaction. And the key outcome was to see how many people were retained at 48 weeks of treatment. In terms of the study, we initially did a cross-sectional survey of 400 people looking at attitudes to the option of this treatment, and found that there was a favorable attitude to an interest in this. And then we progressed to a single-arm, multi-site, open-label study, and we used...
Would you mind sharing your screen with us, please, with the PowerPoint?
Oh, I have it shared, have I not?
We can't see it as yet, Michael, sorry.
Oh, my apologies. Is it up now?
Perfect, thank you.
Okay, so the study, I'll carry on this way, I won't go back, I'll just carry on. The study design is a single-arm study with screening, initial use of sublingual buprenorphine, and then monthly injection. And this carried on for over a year period. And if you look at it, we started it in early 2019, recruited the sites, and then started recruitment. We got very active recruitment and follow-up. And actually just last week, we've managed to complete the last patient for the 1-year follow-up. And the sites involved were DASA in South Australia, Western Health in Melbourne with John Cook, Frankston Healthcare, which is a primary care setting with Rob Weiss, Rankin Court with Craig Rogers, and Mark Montebello in North Sydney, and then up Hunter, New England with Adrian Dunlop in both Cessnock and Newcastle, Cessnock being a type of more rural setting. And here you see the characteristics of the participating sites. The whole idea behind this was to have sites with different characteristics so we could see what the issues were in implementing depot in a type of primary care setting, more community setting, and the more specialist type clinics. So we could explore the issues around staffing and what impact it had in the long term. As James has mentioned, we're very interested to see what implications this has for the broader aspects of treatment. And this provides you with some idea of the characteristics of the participating sites, pretty broad ranging, a mixture of half and half buprenorphine and methadone, reasonable, considerable variation in takeaway type things, and then you see the numbers on Sublocade. And so from the first patient who came in May 2019 up to 2020, So at 6 months, we had 100% recruitment. And then if you look at the characteristics of these, they're the usual type of characteristics of people in these services, but it's worth noting that we were recruiting people who have considerable experience of treatment, and here you see it. There are people who have approximately 4-year duration in either methadone or buprenorphine and have been consistently in treatment for quite a period of time. So if we look at it then, in terms of the 6-month follow-up at the participation, we had 93% retention and majority completing all their injections. And if we look at it beyond that and we look at the research interview retention rate, we had nearly between over 90% retention rate in the study follow-up. So one of the things about this is that with a new treatment, we're interested to see what will happen, because the initial studies showed were ones of a shortish duration, but we've now extended this study so that we will have data for 24 months on people on this, and we will look at the impacts of that and the feedback we're getting from the patients involved, that they're very keen to continue in this treatment. One of the aspects of this was, in terms of mixed methods, was also to undertake qualitative work, and we've conducted qualitative interviews with Carrie Lancaster and Carla Troller on treatment users, service providers, and decision makers to look at the broader impact of treatment and people's views and subjective aspects of this, and that work is nearing completion. We've also undertaken a costing study so that we can actually look at the time involved and whether there is some cost savings around pharmacy time and a range of things, but this will be complicated, and that's underway. So I think when we look into the future is to explore new data around the scale up and choice for consumers, to consider what post-COVID changes will occur around opioid agonist treatment delivery, and to look at increased levels of sublingual buprenorphine takeaway as a strong alternative to depot buprenorphine. So that's my talk for today. Thank you. Back to you, Fadil.
Thanks very much, Michael. Very interesting talk as well. We've got a few questions for both. I think, James, this one directed to you, or more generally, really for both of you. There's a question around whether supervised heroin treatment exists in Australia.
No, not yet. We're hoping to commence a clinical trial in 2021. We would have hoped to do it in 2020, but there was an irritating outbreak of a virus that stopped things.
It stopped a few projects in their tracks.
It certainly did.
Second question is around whether people can eventually overcome the need for IAT through supervised dose reduction, especially with buprenorphine.
Sorry, that slightly confuses me. Yes, people don't stay. Not everyone stays forever on injectable treatment, and actually, quite a few people get very, very bored with the intense requirements for attendance and transfer to largely oral treatment. But it's a delicate process. I believe I personally think that conceptualizing injectable treatment as an intensive intervention for a period of time in an attempt to provide enough structured treatment for really people who have had huge trouble stopping injecting, I think it can be used as a short-term treatment, but that's the aim, or a short-term 2-year treatment is what we're looking at in the study that we're doing in Sydney.
Thanks, James. On the basis of your previous answer, someone's asked if they can put clients forward to the heroin trial and how?
I wish the answer to that, by and large, is no, because it's such an intense demand for attendance, twice daily, 7 days a week. We really need to recruit from local services within central Sydney, and we'll be approaching those people directly.
So you can't self-nominate in a way. Thank you.
No, not unless you live in the right postcodes.
Unless you move into central Sydney.
No, Michael, none of that.
Should someone else has asked, should individuals who are also using high doses of pregabalin or benzodiazepines be offered injectable buprenorphine?
Too much. Most programs around the world regard benzodiazepine use as incompatible with injectable treatment because the risk of overdose is too high. That's the big limitation on injectable treatment, is that people can drop. It's safe because it's highly structured and everyone's under supervision, but it's always unpleasant, and really people should not be using benzos and should wean from benzos if they want to be on injectable treatment.
Okay. There's also a statement, if you like, rather than a question, from anonymous attendee on broader systemic impacts, including depot buprenorphine. Challenges include difficulty for exit planning and ongoing treatment delivery as being hard to engage via GPs, pharmacists, nurses who can provide ongoing support, and a depot bup injection, which may cause a bottleneck in DNA services. Yeah.
Well, I don't know that it'll cause a bottleneck, but I think the issues that James has been discussing around the role of structure and supervision and what being in treatment and not being in treatment other than getting medication, a lot of these issues will come up around depot buprenorphine, and they'll need to be explored in a structured way. And it'll solve some problems, but as James said also, it'll probably create some other problems.
Thanks, Michael. And I'm not sure if we can answer this question yet, but what has been the experience and impact of increased takeaways policy this year?
So there was a presentation yesterday at the ABSAT seminar by Nick Lanzeris, which showed actually very mixed results, but generally pretty beneficial. Which has been very interesting to see. Of course, it's over a unique time of the COVID pandemic, but they show a before and after thing, with a few people doing worse, but many actually doing quite well with increased takeaways, and substantial, but far more increased takeaways around buprenorphine and less so around methadone.
Yeah, maybe I could make a comment that one of the intriguing questions is why people on sublingual buprenorphine would not wish to transfer to depot. And I'm doing a little study in a very remote location in Burke, where the commonest street drug is in fact Suboxone. That is the drug that people divert and inject. You can find these things out in a little community. It's much harder in the city. But I think there remains an issue of diversion, and how people do when they get increased takeaways is one question, but it's what happens to the community supply of drugs that is the other unanswered question.
Yeah, just to add to that, James, we are undertaking at the moment a preference survey with a sort of fairly structured approach to it. And interestingly enough, of those opting for buprenorphine, it looks like it's a half and half thing, where half would opt for oral medication and half would opt for the depot, and issues around that. We're interested to explore issues around that into the future with some type of randomized consent design study.
Michael, if I can ask this question on behalf of all researchers in the audience, that's an extraordinary retention rate in terms of interview follow-up. What do you put that down to?
I put that down to the excellence of the research team and the clinical teams who've worked in partnership, in great partnership, to actually really make it a high quality study. And we're very, very grateful for the diligence and application of both the clinical teams and the research team.
There's a related question, I guess, around the 5 to 10% who stopped BOOP injections. What's happened to them? Have they reverted to sublingual or dropped out?
A few of them have disappeared. 1 or 2 of them went into prison, and they could potentially have continued on it, but they were out of the study. And a few of them have reverted to oral medication. So it's been a bit of a mixture.
A range of experiences. And the final question for us today, for this morning's session, what are your experiences of people coming off long-acting injectable treatment?
Well, it's early days, but there's a lot of interest in this. My own personal view of it is that it's no different than coming off oral medication from the point of view of the risks with the loss of tolerance, but actually whether there'll be structured, whether it provides a new structure for withdrawal needs further exploration. James, anything to add to that?
I think the question was about injectable heroin or hydromorphone, was it, or was it about it?
I think, James, one of the interesting issues is we're going to have to get our terminology correct.
Correct.
Because we've now got injectable buprenorphine as depot, and people use these terms, and it is actually gets confusing.
Well, I think depot is depot, myself, and injectable means whacking something in your arm on a daily basis, and you're coming off it is not the same risk, because you would normally transfer progressively from daily injectable treatment to less frequent injectable treatment, but with oral methadone or sublingual buprenorphine, and it's a transition not to a drug-free state, but to to oral treatment.
It's probably worthwhile telling people, James, that you ran the heroin program in Denmark Hill for many years.
I did indeed, and it was a learning experience.
We did it partly in partnership.
And we did. And what I just, if I could make one little comment, it was a tiny clinic, it was highly staffed, and it was such a pleasure to work in compared to any of the large industrialized dispensing operations that I've previously worked in. And we really did establish a close relationship with the patients, and they often got sick of daily attendance and would come less frequently. It's a gradual weaning process, but it takes time, and you can't push people too hard.
Sorry, I think there's another question for you, Michael, around the trial. Have there been any adverse events or side effects?
There's been some side effects, but nothing, no major adverse events.
Thank you. And what about OAT therapy and borderline personality disorder?
I think my personal view is that it's actually works pretty well if you have experienced practitioners. It's the medication isn't the issue. It's the effective long-term management of borderline personality disorder, which is to have somebody with experience, patience, and time, and a steady focus on achievable goals.
Thanks, Michael. We'll have to close it off shortly. Lots of questions. In the community, would you only put people on injectable BOOP or already stable on oral BOOP?
Well, I think that currently is the licensed indication, but as with other types of depot medication, I think the future will see exploration of other indications.
Thanks very much, Michael. Look, I do have one more question for you, James, if you don't mind. You talked about the importance of structure. What do you think are the critical elements of structure in increasing retention and impact?
I think structure is the therapeutic element that people feel that that they have a reason why they're there. They understand the basis of treatment. I think that I remember a chap at a meeting I was at in London, one of the user representatives, who said, "Look, when I walk into a clinic, I want to know where the exit is in the long term. And I think people do need, benefit from, and value structure. That's all, and that's a totally unscientific, appallingly ignorant remark to make, which has no evidence base whatsoever. But it's my observation over many years is that this is a helpful component of treatment.
Sure. Thanks very much for clarifying that, James.
And just before you finish, Fadil, it's Ball and Ross in that talked about, in terms of structure, they talked about simply clinics being well organised and staff having clear understanding of their role and function.
I guess it gives people in treatment more security and certainty about, as you're saying, and knowing where the exit sign is, where the light is. Perhaps.
And it also feels as though the treatment is not low quality, that they're not being treated shabbily. That's, a very basic element.
Absolutely. Quality of treatment context as well. Thank you both very much. Much appreciate your input this morning and generate some good questions. We'll now turn to our featured poster presentations. There are five featured poster presentations. They all run for 2 minutes each. This will be followed by 2 more presentations and a panel discussion. So we still have a presentation from Dr. Nadine Ezard and Associate Professor Rebecca McKetton. We'll see you shortly after the poster presentations. Thanks very much.
Chronic non-cancer pain affects 1 in 5 Australian adults, with huge personal, societal and economic costs. Guidelines recommend multimodal treatment approaches, including health services such as physical and psychological therapies, with strong evidence that these services may lead to reduced pain severity and improved functioning. Medicines including opioid and non-opioid analgesics and adjuvants may be associated with short-term reductions in pain severity. However, evidence of long-term or functional benefits is limited. The use of these different treatments among Australians with chronic non-cancer pain is not well known. Among the pain and opioids and treatment study cohort of 1,514 Australians taking opioids for chronic non-cancer pain, we examined health service use and medicine use at baseline and over 5 years of follow-up. 3/4 of participants used a service at least once, while 9 out of 10 used a non-opioid medicine for pain. Most services were used at 1 or 2 waves, and only 4% used any service at all 6 waves. Over 40% of participants used opioids and over 40% used non-opioid medicines for pain at all 6 waves. Several factors were associated with service use. Chronic non-cancer pain prevalence is likely to increase as the population ages. Therefore, the negative association between service use and increased age we identified requires exploration. Private health insurance was associated with increased service use, and with only half of the population holding any form of private health insurance, many Australians may be missing out on evidence-based services. And finally, higher pain interference was associated with service use. An understanding of how people choose treatments for pain is required, and we're currently undertaking qualitative work to understand the choices and experiences of Australians with chronic non-cancer pain as they access health services.
Hi, my name's Liam and I'm a PhD student at NDARC and Research Officer at St Vincent's Hospital, Sydney. And today I'll be presenting our analysis of discharge against medical advice and incomplete treatment for people who inject drugs. We know that people who inject drugs are at increased risk of leaving hospital early or against medical advice, but also at higher risk of serious bloodborne infection. However, the reasons for discharge against medical advice in this population still remain unclear. So we therefore sought to establish the rates of treatment completion and discharge against medical advice for people who inject drugs, but also examine the reasons and rationale behind why people who inject drugs are leaving hospital early or against medical advice. To do this, we conducted a retrospective record review of all patients who were admitted to the hospital with a Staphylococcus aureus infection between 2015 and 2018. We then followed this up with qualitative one-on-one interviews with current inpatients who identify as a person who injects drugs and were admitted to the ward with a serious infection, but also with the clinical staff members who regularly take care of these patients, but are not engaged with the drug and alcohol service. We found that up to 41% of our people who inject drugs patients with serious infection were discharging against medical advice. And we were able to pull out 4 key themes which influenced a person's decision to self-discharge. These themes were stigma and discrimination, social issues, pain management and substance use, and communication and patient-centered care. We found that people who inject drugs were significantly more likely to discharge against medical advice, and that our patients may be placing their social or psychological needs above their physical treatment needs. However, we also found that non-judgmental and supportive care assisted our patients to stay in hospital for longer, but more still needs to be done to protect vulnerable patients and facilitate treatment completion. Thank you.
My name is Samantha College. I'm a PhD candidate at NDARC, and the title of my poster is Injecting Related Injuries and Diseases Among a Sample of People Who Inject Drugs in Australia. Our study aimed to do 3 things. First, estimate the number and proportion of participants who reported certain injecting related injuries and diseases. 2, determine clusters of participants based on their reporting of these harms using latent class analysis modelling. And 3, determine which characteristics and drug use practices were associated with these clusters, which we did using class-weighted regression analysis. In the 2019 Illicit drug reporting system, there were 897 people who injected drugs that had answered the questions regarding whether they had experienced these injecting-related injuries and diseases on the side in the previous month. In our sample, 34% of participants had experienced at least one type of IRID in the previous month. From our latent class analysis, we found that the 3-class model was the best fit and resulted in this theoretically distinguishable groups that indicated a spectrum of severity. From the regression analysis, we found that reporting reusing your own needle in the past month was much more likely in the higher IRID group compared to the moderate group, and much more likely in the moderate group compared to the no IRID group. Based on our findings, we think there needs to be a significant improvement in needle and syringe coverage so that every injection is covered. Avoiding clotting disorders like thrombophlebitis might be helped with improving injecting technique and messaging around pain care. And implementing screening for lower risk harms like skin infections at low threshold services might help reduce the burden of these harms, particularly those that can become systemic and fatal. Our findings represent self-report data, which may be biased in a number of ways. And we didn't include every type of injecting related harm, although we think many warrant further investigation. Thank you so much.
I'd like to begin today by acknowledging the traditional owners of the land on which I'm presenting, and would like to pay my respects to elders past and present. My name is Tom, and I'm a PhD candidate at NDARC. Today I'll be presenting the findings of a systematic review and meta-analysis on the prevalence of childhood maltreatment among people with opioid use disorder. Opioid use disorder is a major public health issue, and one risk factor is the history of childhood maltreatment. Childhood maltreatment is the experience of abuse or neglect during childhood and is associated with a range of adverse health and social outcomes. Estimates of childhood maltreatment prevalence have been completed in community samples and other populations, but there has not yet been a review of childhood maltreatment prevalence among people with opioid use disorder. The aim of the current review was to estimate the prevalence of each form of childhood maltreatment among people with opioid use disorder and examine factors associated with variance. Finally, we compared estimates from the current review to comparable estimates from community samples. We searched 3 major databases and pulled estimates for each type of childhood maltreatment separately. We used random effects meta-analyses, and we also stratified estimates of sexual abuse by sex. We included 62 studies and over 21 individual observations in our primary analysis. Physical and sexual abuse was most commonly reported, and women and people with a history of injecting drug use reported higher rates of multiple forms. People with opioid use disorder reported significantly higher rates of all forms of childhood maltreatment when compared to community samples, excluding emotional abuse. In conclusion, childhood maltreatment is common among people with opioid use disorder, which emphasizes the importance of trauma-informed interventions, particularly for certain subpopulations. Future research should consider the impact of childhood maltreatment on course of OUD and use gold standard definitions.
My name is Lee Cooney. I'm a PhD candidate at NDARC. Crypto markets are eBay-style, online, anonymous drug marketplaces. They're also called the darknet or deep web. crypto markets could increase harm by facilitating solitary drug use. Because they don't need people to source for drugs, they could be using drugs alone, being at a heightened risk of adverse drug events. We used the Global Drug Survey 2018 to look at the relationship between crypto market use, social networks, and adverse drug events. People who use crypto markets were more likely to report adverse drug events for cocaine and LSD. They were also more likely to be alone when using MDMA, cocaine, and LSD compared to people who did not use crypto markets. When it comes to reasons for not seeking emergency medical treatment, being alone was more common for crypto market users, for MDMA and LSD. Also, for LSD, friends advising them not to seek help when requiring help. So the results suggest a possible increased risk for people who use crypto markets, but there may be other variables at play. For example, age. People who use crypto markets are younger, but so are people who report adverse drug events. Also, when looking at social networks, we need to take into account the possible negative influence that some social networks may have, like when friends advise not to seek help when requiring it, in order to get a more complete picture of a relationship between social networks, adverse drug events, and crypto market use. Thank you.
We presented trends in methamphetamine-related harms as part of a study involving my co-authors listed here. There has been considerable growth in the global market for amphetamine-type stimulants, driven predominantly by methamphetamine. The shift to the high-purity crystalline form and its association with greater harms also raised concerns. We obtained the national-level administrative data and identified records related to amphetamine-type stimulants, or ATS. Autoregressive time series analysis of change point models were used to detect up to 3 time points at which there was a change in trend. I refer you to the poster for detail on methods and results. Here we see that treatment for ATS as a principal drug of concern was relatively stable until around 2008, when treatment rates decreased for a short period before increasing from around 2010 onwards, with an almost 5-fold increase in observed rates in the 8-year period. The trend for ATS as any drug of concern is relatively parallel to that for principal drug of concern. For hospitalization, rates were relatively stable until around 2010, when they increased before plateauing from around 2016 onwards. ATS-induced death rate have been relatively low until around 2012, from which it increased. While rates appeared to have plateaued in 2016, death records in 2016 to 18 are subject to further revisions. We see increase in rates of ATS-related treatment, hospitalization, and deaths from around 2010 to 2012 onwards in Australia. While it might have stabilized in more recent years, trends from various data sources need to be continually monitored.
That was the last of our 7 poster presentations. Please don't forget that you can view all of the poster presentations online from today and from previous sessions of the symposium. It's time now for our 3rd presentation of the morning. This one is being delivered by Dr. Nadine Azard. Nadine is Conjoint Professor and Director of NCRED. She's also the Clinical Director of the Alcohol and Drug Service at St Vincent's Hospital, home to one of New South Wales' first specialist stimulant treatment programs. The title of the presentation this morning is NCRED, Bringing Researchers and Clinicians Together, highlight on methamphetamine. Thanks, Nadine.
Thanks, Fadil. And I'm pleased to be here today. There's a question here from Amila Sriskanda that says, is pharmacotherapy available for addiction to methamphetamine, which is just a fabulous segue into my presentation, because the short answer is no, but I'm about to tell you what we are trying to do to address that question. Why is my slide not moving? Sorry, I've just got to... There's a little bit of a delay there. So I'm talking on behalf of the National Centre for Clinical Research on Emerging Drugs with my co-authors Krista and Duncan, who will be with us in the audience today, not that we can see them. This is a new centre that was established to bring researchers and clinicians together to address very much this question on how can we improve our treatments for methamphetamine. We've heard a lot today about progress with opioid treatment. Cannabis treatment is progressing, alcohol treatment has been developed over many years, but the methamphetamine treatment sector is a reasonably younger area, and one that Australia kind of leads on, in the sense that we have one of the highest rates of methamphetamine related harm in the world. So we this initiative is a consortium initiative, so it's a new way of working together to develop some new interventions and work with the sector to drive clinical innovation. And it's a collaborative effort between the 4 consortium partners, which are NDARC and the National Drug Research Institute in Western Australia, the National Centre for Education and Training and Addiction in Adelaide, and St Vincent's Health Australia as the clinical partner. And here you'll see on the board, Anthony Shembry represents St Vincent's on that board. So, but the board also brings in other elements of the sector. So we have Adrian Dunlop, who is from a clinical service that's government funded. We have Annalise Stern, who is representing or is an Aboriginal identified person on the board to help us develop that area of our work. Nick Linzeris, who's the chair of Australia's only clinical research network that's registered with ACTA, and Robert Sterling from NADA, the New South Wales Association of Drug and Alcohol Agencies, as the NGO representative, as well as Melanie Walker, who represents the consumer orgs. And we are fortunate at the moment to be chaired by Ingrid Van Beek, who many of you will know, taking over from Margaret Hamilton. We're a small team. You can see there at the top left, going from left to right, top to bottom, is Krista Seafried, who's our clinical research lead. And she herself has a clinical background as a nurse before she moved on to clinical research and doing a PhD. Liam, you've already met. He's doing a PhD with NDARC and with NCRAD and works at St Vincent's as a research officer. Gemma Halen's our project officer. Moving down to the next line, Florence Bascombe is working on the translational arm. Penny Hill has just joined us to drive the prompt response network, which you'll hear about in a minute. And Duncan Graham, who is writing our products and all of our reports for us. So we're grateful to him joining the team as well. So there are 3 core strategies to the way that NCRED does this work of collaborating and embedding research into clinical practice. So the first one is to look at generating new evidence-based knowledge. The second one is collaborating to build the capacity to conduct research. And the third is to translate effective research into effective clinical practice. To drive the actual direction of the research, because it is, as you're aware, it's an undermet problem, methamphetamine use disorders, with very little research effort compared to the size and scope of the problem, which, I mean, everyone here will be well aware that substance use disorders are as prevalent as some of the other chronic illnesses, or such as diabetes or asthma, and that methamphetamine particularly has been subject to under research effort. So to direct the effort of NCRED and its partners, the team conducted an online survey and some kind of Delphi process for expert opinion, just to identify some of the top areas of research for both methamphetamine and other emerging drugs that might be coming forward for us in Australia. So for methamphetamine, the 3 areas that were of interest out of that priority setting study, and this is about to be published, this paper, I can share it with you when it's published. The first was overcoming barriers to intervention uptake. So looking that that people with methamphetamine methamphetamine use disorders often collide with the health system in crisis in the emergency department, or might present to a primary healthcare setting, to a GP, but there's no linkage then into treatment settings. So how to link those two things better together. The need for pilot pharmacotherapy trials, which goes back to the question that we had before, and pilot because a full pharmacotherapy trial, as everyone's aware, is extremely expensive, and this is NCRED is funded time limited from the federal government. And then finally, communication strategies for consumers and their families on what the evidence-based treatment options are out there, so that there's a comprehension that treatment is not only limited to residential rehabilitation for people with very severe disorder and social disruption, that there is a range of treatments and harm reduction efforts that might be beneficial for people. And for emerging drugs, at the time we did this survey, drug checking or pill checking was really at the top of people's minds. So looking at how that might be effective in embedding into some kind of early warning system. And social media, linked to the drug checking and pill checking perhaps, but social media or other kind of creative ways of communicating with consumers to reduce harms. GHB overdose and withdrawal management is an emerging concern. It's an emerging concern for me clinically, and it seemed to be an emerging concern for the people that were involved in setting these priorities. So that made it to the list. And finally, some kind of shared information system to reduce harm and close the gap between harms emerging and us as the healthcare sector responding. So with those priorities in mind, NCRED released some funding. So there was a capacity building round and 3 seed funding rounds. So the capacity building rounds, you can see there on the screen, the three projects that were awarded back in about 18 months ago. Sorry, can you hear me? Something's happened. Are you still seeing me?
Yes, we are.
Sorry, there's some glitches happening here at my end. Please let me know, Fadil, if it goes off completely. So the first is an interesting project, just looking at data that's already been collected across 6 New South Wales LHDs, that so outcomes data, because we really don't have a lot in the sense of understanding what outcomes we're collecting and what works and what doesn't. So to drive our kind of clinical effort, reviewing what data we've already got was a good place to start. So Nick Linzeris led this project with a number of people, and for anyone that attended our symposium last week, Emma Black and Lou Mills presented some of their data, and it's really quite interesting looking at that amphetamine type stimulants, basically methamphetamine, were commonly used regardless of the priority drug of concern. So even if someone presented with opioid use disorder as their primary drug of concern, that amphetamines were still very commonly used. So we know that one of the commonest population that's using methamphetamine in the treatment sector is actually the group that is attending for opioid treatment, and we're not really addressing that co-occurring use disorder there. So that's something that that's great to have that kind of outcomes data to promote that thinking. The other thing that was interesting was that amongst people on opioid agonist therapy or in the opioid treatment program, that clients reporting methamphetamine use at the start were actually more unstable for the first 12 months in terms of their opioid use, and that the co-use of methamphetamine was a destabilizing element, but that after 12 months those differences went away. So if you can assist people to remain in treatment, then the stability improves. The other capacity building grant was to Prince Alfred to join our multi-site NH&MRC funded lisdexamphetamine for methamphetamine dependence. Again, this question about is there a pharmacological treatment, that's one trial that's going on, and it's great that RPA could join that trial. The other trial, Rebecca's going to be talking about straight after me, so we can hear the results. First ever presentation of those results, so that should help to answer that question as well. And finally, the South Australian drug early warning system. So Peter Stolcom also presented these results on last Friday and showed that most of the patients presenting to the ED that actually had tests through this system were presenting with methamphetamine in their system, but that actually many also had GHB, and their presentation was for GHB overdose, and despite the presence of methamphetamine in their blood. The seed funding recipients, so already some of these have started to see some outcomes, and again, Jess Soderstrom presented last week on the EDNA, which she calls the backbone of the prompt response network. So that's a network around Australia of data that's coming from emergency departments around the kind of drugs that might be causing presentations as a signal attempt for detecting new and emerging drugs of concern. And they're working now on establishing a national minimum data set and what the core data elements of that would be. There's the Sentinel surveillance for illicitly manufactured fentanyl in an inner city opioid agonist program, and also another one that you'll see a little bit later from Rachel Sutherland. We don't yet have the final results, but those little seed projects will be really important to assist us in answering this question that we are seeing at the moment with emerging concerns around fentanyl overdose and fentanyl use in both cocaine and heroin. So we've already been collectively around Australia talking about whether fentanyl might be a concern for us in Australia or not, and that question is ongoing and becoming perhaps increasingly pressured at the moment. So that having these projects in the wings is going to be very useful for us, I think, going forward. Ketamine, we don't have results of these things, but in terms of that search for a pharmacotherapy, Jill Betty is leading a study of sub-anesthetic ketamine for methamphetamine use disorder in young people. We're also not only interested in pharmacotherapies, obviously, so it's really great that Pete Kelly has started work on looking at smart recovery, and Victoria Manning and her group is looking at personal approach bias modification. And the online therapeutic program that James Ward and Rachel Riley presented some of that work last Friday as well. That's a different type of intervention that's using online assisted approaches to, in this particular case, working with Aboriginal and Torres Strait Islander people. And Rachel Sutherland's fentanyl strip that I mentioned before, that again will be very of great use going forward with, potentially could be of use going forward with our concerns around fentanyl. Excuse me. Round 3, the funding, as you'll be aware, I mean, COVID has disrupted all of this research effort. And so round 3 haven't actually begun yet, but you can see there on the screen the kind of exciting directions that some people are taking this in. And again, interest in new medications, oxytocin, but then also risk communication that will tie into the prompt response network, which I'll talk about in a minute. In addition to the seed funding, we do have clinical research scholarships. We've just launched the second round, and those people will be announced very soon. The first round are the people on the screen, and their projects are tied to some of those seed funding that I presented before, but really happy to have an ED physician, a psychiatrist, and a clinical psychologist being awarded those research scholarships to expand their research capacity as clinicians, as practicing clinicians. The next round was targeted at nursing and allied health, and we'll be able to present those soon. NCRED itself is leading a couple of partnership clinical research projects together with other partners to build that partnership aspect and that collaborative aspect. The first one, again, using lisdexamfetamine, but this time for methamphetamine withdrawal. The pilot is Liam's PhD. You've heard from Liam earlier, and that will be just done in one site. And then there's a multi-site randomized control trial aspirations, including our colleagues in Victoria and Queensland and Western Australia. That will be very exciting should the pilot look like it is worth proceeding with. We also are establishing a partnership project with ACON, WAC in Western Australia, and Thorn Harbour Health in Victoria, looking at GHB overdose prevention amongst LGBTQ populations. That's being started. I already mentioned the Lima trial, which was paused during COVID. We hope to complete that within the next 12 months. And the S-Check app, which Fadil will be aware of, the New South Wales Health is funding that trial, and NCRED's assisting to expand it nationally. And should this be at all interesting to consumers, that the next phase would be to look at embedding that or linking that with a clinically assisted project, perhaps with GPs or with drug and alcohol counsellors. And finally, the third activity is translation, and we've had a range of translation activities. You saw that's Florence Bascombe is the lead on this, and the first project, I guess, was a systematic review of pharmacological treatment of methamphetamine or amphetamine dependence, and Krista led that. And out of that, we developed an outcomes framework and matrix, which is available on the web, so that we can start to move towards perhaps using some common outcome measures in research at least. There are also a number of clinical practice guidelines, models of care webinars that you can see on the web, but that's the direction that we're looking at, using the evidence to assist people in their practice. And finally, the collaboration element. There's two big projects in the collaboration element. The first one is the Prompt Response Network, which is an information sharing system across jurisdictions. And we've established a closed network forum with various players in different jurisdictions to informally share alerts or information before perhaps going out to a larger public audience. And there'll be a consumer piece to that too, that looks at the consumer facing network that is about information sharing from consumers and to consumers, and with the eventual aim of assisting people to reduce harm associated with use of emerging drugs of concern. And the other big project is the Clinical Research Network Working Group, and the working group has been established with people from all over Australia with interest in or experience of clinical research. That's chaired by Robert Alai. And one of the aims of that working group is to oversee the research directions of NCRED and to oversee the seed and scholarship funding programs, but also to start working with the sector more broadly to explore the need for, scope of and purpose of potentially a national clinical research network for the sector, and what that relationship might be with NCRED, building on the real aim of collaborating to embed research into clinical practice, and putting the consumer really at the core of everything we do. So every research project needs to have some kind of consumer engagement, consumer advisory panel, consumer direction from the research question all the way through to writing up the findings and disseminating them. But one of the big values, I think, is bringing people together to develop collective thinking, and we're already seeing some slight maturation in the research efforts in methamphetamine, with more nuanced investigation of interventions by severity of disorder at baseline. And we're hoping that these kind of developments are going to progress into the future, and as we continue our efforts to deliver another round of small seed funding grants, to deliver the fellowships, to work towards the clinical research network, and to really establish the prompt response network in a more public way. And so they're the future directions for us. And any further questions, you can ask me, or you can ask Krista, who's our clinical research lead. Thank you.
Thank you very much, Nadine. It's great to hear about further progress in this really important national network about emerging drugs. Seems to have some inbuilt mechanisms for prompt response and translation as well, which is great to hear. Thanks again. If I can introduce our final speaker for the afternoon, Associate Professor Rebecca McKetton. Thanks, Rebecca, for joining us. Associate Professor Rebecca McKetton leads a program of research into stimulant use of epidemiology and interventions at NDARC. Her current research involves the online delivery of psychological help for people who use stimulants, trialling of new pharmacotherapy options for methamphetamine dependence, and the development of novel responses to methamphetamine use in Aboriginal and Torres Strait Islander communities. She'll be presenting today on findings from the NICE trial, a randomized double-blind placebo-controlled study of the safety and efficacy of NAC as a pharmacotherapy for methamphetamine or ice dependence. Thanks, Rebecca.
Thanks, Fidel. I'll just share my screen here, and I hope that you can all see the presentation now. Yeah, so as Fidel has mentioned, I'll be talking about the findings from the NICE trial, which is a double-blind randomized controlled trial of N-acetylcysteine for methamphetamine dependence. And just so you understand the rationale for this, N-acetylcysteine is a prodrug for cysteine, which has the potential to restore glutamate homeostasis in addiction, which is basically glutamate is thought to be disrupted. The regulation of that particular chemical in the brain is disrupted when people are addicted to stimulants or other drugs, and cysteine can help restore that disruption. It's been found in preclinical studies to reduce drug seeking, and in human studies, it's been found to reduce drug craving across various different types of drugs, including methamphetamine. But it hasn't been tested on methamphetamine use per se. So we know it can reduce craving, but we don't know whether it can reduce use. And that was the motivation for this study. It's also conveniently a very potent antioxidant. If you work in emergency medicine, you'll recognize acetylcysteine because it's used in paracetamol overdose. It has a similar property in context of methamphetamine use in that it can reduce toxicity. So it's actually protective against methamphetamine-induced neurotoxicity. So this background has led us to two ideas. The primary idea is that hopefully it will be able to reduce days of methamphetamine use, and we've got two measures of that, days of use, and we also took oral fluid samples from people. We're looking at the percentage of methamphetamine positive oral fluid samples. Then we had secondary outcomes, some of which were related to methamphetamine use, the craving, severity of dependence and withdrawal, but we also were interested in the psychiatric symptoms, and that's because some of these are related to the oxidative stress and neurotoxicity from methamphetamine use. So we're hoping that if this drug could alleviate that neurotoxicity, that it might reduce some of the harms that we see in terms of psychiatric symptoms. And there is indeed evidence from the broader psychiatric literature that N-acetylcysteine can reduce some psychiatric symptoms in people with psychiatric disorders. So we were able to recruit 153 people, randomize 153 people for the trial. We actually had an incredibly good response from people, and a lot of the people that we excluded because we couldn't get them into the trial. They just ended up waitlisted. Half went into NAC, half went into placebo. They got 12 weeks of NAC, it's take-home medication, or 12 weeks of placebo, so it's double blind. We had good adherence compared to previous methamphetamine pharmacotherapy trials, but overall it was 67%, which is still suboptimal. You really want more than 80% adherence. So that's a challenge that we are facing. Overall, we had 69% of our follow-up assessments done. They were weekly, so very intensive follow-up with people. But the good thing is, with our measure of days of use, it didn't matter if someone missed an assessment here or there, because we were doing them weekly, we could actually track back to the previous assessment. And that meant overall we had 88% complete data on our primary outcome of days of use. For the oral fluid tests, because that required face-to-face contact at each weekly assessment, that was lower. And a little bit less in the NAC group than in the placebo group. So that's the method. What did we find? So this graph shows you median days of use in the bars, and you can see here at the start of the trial at baseline, people had used on a median of about 24 days in the past 28 days. So we had a group of people who were using the drug very heavily. The dark bar is the placebo, the white bar is the NAC group. And you can see here what's happened 4 weeks into, this is all on medication here, 4 weeks into the trial, 8 weeks into the trial, and 12 weeks into the trial. Both groups reduced their use significantly down to around 15, 16 days in the past month. So significant reduction in use. However, NAC did not reduce use more than placebo. So we have no effect of NAC on days of use. You can see here in the lines that we have the percentage positive methamphetamine oral fluid samples. That's on the axis over here on the right-hand side. And you can see no difference between the groups there. We also looked at craving, and we saw strong reductions in craving from baseline to the rest of the trial. However, there was no difference between NAC and placebo, so we have no effect on craving. The same pattern of results for severity of dependence. People reduced their severity of dependence once they're in the trial, but it made no difference whether they're on NAC or placebo, and the same pattern of results for withdrawal, absolutely no difference between groups. Looking at psychiatric symptoms, so psychotic symptoms in this context is symptoms of paranoia and hallucinations. So feeling overly suspicious and seeing things that aren't there. They're usually fairly mild in this population, but in this context, we can see firstly a lot of variability in symptoms, But we are not seeing any clear difference between the NAC group and the placebo group. The NAC group is in black, the NAC group is in blue, the placebo group is in black. So placebo is always black in these graphs. Same for depression, we didn't see any significant difference between the groups. And even though it looks like there might be some separation here between the NAC group and the placebo group, there was no significant effect of NAC on suicidality. However, one little glimmer of promise here is in terms of hostility. So our measure of hostility would be whether someone was overtly angry, yelling at someone, maybe throwing things around, breaking furniture, right through to hitting someone. And on this measure, you can see here that the black group is the NAC group had quite a lot higher proportion reporting hostility compared to the NAC group. Now, when we tested this, we can see quite a large effect. However, we had quite stringent criteria for what we call a statistically significant result, and we just missed that. It should have been less than 0.01 and we got 0.02. So we can only regard that as a trend. In conclusion, N-acetylcysteine didn't work. Take home oral NAC did not reduce meth use relative to placebo in this group of people who are dependent on meth and using very heavily, nor did it reduce craving, severity of dependence or withdrawal, or most psychiatric symptoms. But it might reduce hostility. We have to be very cautious about interpreting that effect. However, there have been a couple of trials in autism of N-acetylcysteine which have had a similar result where it's reduced irritability. So that's something we'll be looking into in a little bit more detail. If you're interested in the full results of the study, they'll be available via our website, www.nicetrial.info. And in closing, I'd like to thank the many wonderful people who worked on this trial. And this is but a few faces. You can see here a very long list of people who've been part of this effort, which has taken several years to complete. Particularly the participants and people who inquired about the study. I'd like to thank them in particular. So thank you.
Thanks very much, Rebecca. Nadine, if I can invite you to put your camera back on and microphone. Thank you so much. Two fascinating presentations. We don't have any questions so far. I've got one, Rebecca, around the findings. Obviously, something of a trend in terms of the impact on hostility, not significant one. But have you got any theories around why that particular effect, as opposed to other variables that you measured?
Yeah, our team have had a bit of a discussion around it. I mean, I think the first thing to say is we have a lot of secondary outcome measures, and it may just be a type 1 error rate, type 1 error. So we have to be very cautious, and I think that we need to replicate the effect and understand what is driving it. If it is a true effect, I mean, there are a number of possible mechanisms. So like I mentioned, methamphetamine can be neurotoxic because it causes oxidative stress in the brain, and NAC can protect against that. So it might be protecting against the oxidative stress, which can lead to serotonin toxicity, and that's related to aggression. It might also be related to cognitive function and impulse control. So one of the other things that NAC has been found to do is improve cognitive function. And it might be that people are still feeling irritable, but they might have a better control over their behavior. So there are different possible mechanisms, but this is very speculative.
Sure. Thanks very much. We have a question from Steph. Are there side effects to NAC? So can you perhaps use it as a preventive measure, a bit like a vitamin?
So it is actually a nutritional supplement, and it's already used in medicine to treat paracetamol overdose and emphysema. And so it's got quite a well-established side effect profile, and the known side effects are gastrointestinal upset. And the other one is sometimes people get a rash, and it is possible to get an allergic reaction in some cases. So they're the known adverse reactions. In our trial, we didn't see any difference between placebo and NAC in terms of those side effects, though. So I think if you were interested in taking it as a preventative supplements, it's probably still best to talk to your like a medical doctor about the potential interactions it might have with other medications you're on or your other medical conditions.
Great. Thanks very much. I think we have potentially some other questions from other people online. Agatha? Sorry, Jacob, I can see in the chat here there's Saki and Agatha who could be adding to the Q&A. No? Well, my apologies, misunderstood. Bad sharing. Do you need a script to obtain NAC?
It's not actually an approved medication. Well, you would need a script to obtain NAC if you were using the other formulations for paracetamol overdose or emphysema. However, they're in a different formulation than what we've used. And so the formulation we used is just an oral formulation, and that's not available on prescription in Australia. So you wouldn't be able to get it. The only way you could get it is either via the internet and importing it from another country, because it's more freely available in other countries. And I'm not suggesting you do that, because you've got to be very careful about where it's produced and the standards to which it's produced, so you actually know what you're getting. But the other option that we suggest to people is approaching a compounding pharmacy. And they're usually able to provide it. And I would still suggest going to your doctor first, even if it's not a formal script. At least they can provide advice on the dosage and side effects.
Always sensible advice. I think, Nadine, it's a sign of how long NCRED's been around that there's so few questions around the work that you've been doing.
We're very new.
The wastewater data seem to show a decline in fentanyl use. Is that our impression? Claire asks.
I think, Nadine, you're going to have to answer that one.
I think we need to be cautious with using wastewater data as a single source of information around trends around drug use and related harms. There are a number of issues with wastewater data. It's useful as one of many data sources when you're putting together a picture using evidence from a range of sources. So I wouldn't be drawing any conclusion about declining fentanyl use from wastewater data at the moment. And we certainly are around Australia hearing, small anecdotal reports of fentanyl related harms amongst people who are using drugs. So I think we still need to be on high alert at this current moment. The question also is whether it's pharmaceutical fentanyl or illicitly produced and manufactured fentanyl, and that's also reasonably topical at the moment around our preparedness for potential drug supply of illicit fentanyls in this country. So it's still a watch and wait, I think, at the moment.
Thanks, Nadine. Thanks, Rebecca. I might close it off at this stage. Questions, thank you very much. Before closing off the discussion and inviting Michael to turn his camera and microphone on, to deliver closing remarks, I did just want to say thank you on behalf of the New South Wales Ministry of Health to NDARC for inviting us to be a part of the symposium this year. Much appreciated, and it's been very successful. Thank you.
And Fadil, thank you for all your help and support, much appreciated. So I've got two things to do now. I've got to announce the e-poster presentation, and the outstanding e-poster presentation for 2020 NDARC Annual Research Symposium has been won by Agata Szymanowska, who, for her poster, Exploring Trends in Cocaine Treatment Episodes, Finding from Drug Trends. Agata joined NDARC as a research officer in December 2018, and she's working on hospital administrative data. And the poster highlights findings from analyzing the Alcohol and Other Drug Treatment Services National Minimum Data Set. And the results showed that the recent increase in the rates of cocaine treatment episodes was not driven by any treatment or socio-demographic characteristics. And she will be receiving a $250 award, which for the purposes of study and learning and development. Well done, Agata. Congratulations.
Thank you very much. Much appreciated. Thank you.
And So we'll talk to you later. Thanks. And then the People's Choice e-poster presentation for 2020 for the annual symposium was determined by the highest number of votes via an online voting system. And that's been won by Saki Talkadar for her poster, Inequality in Smoking Cessation Clinical Trials, Exclusion of Smokers with Mental Health Disorder. Saki joined NDARC in 2018, and she's currently working on the CESATE study, which is comparing cytosine with varenicline. And her poster highlighted data that was analysed from the Cochrane database and showed that there's a need for careful consideration and transparent reporting and justification for exclusion in smoking cessation ORCT. So congratulations, Saki.
Thank you, Michael. I'm very happy to receive the award, and I'm glad everyone liked my poster. And also thanks to my supervisor for their guidance with my work. And this award will be an inspiration for my career. Thank you.
Well done. And now I'd like to thank all the presenters of the 4 sessions. This has been extremely successful with very high viewing and very positive feedback. And I'd like to thank the session chairs, Amy Peacock, Anthony Shakeshaft, Hayden McRobbie, and today Fadil Padik. All of those who submitted a poster in the poster presentation, and particularly all our viewers who logged on and got involved and asked questions. And also the organizers, Jacob Webb, Emily Stockings, Gemma Sale, Amy Peacock, Rachel Sutherland, Anthony Shakeshaft, and Lise Meller, and the operations team at NDARC. So as we finish, just to be aware, you can rewatch all of the sessions on the NDARC website. We'd really love your feedback on what you've liked about the webinars this year and what you'd like to see for 2021. There's a survey online. You will be emailed a link. Please fill it out so we can tailor our webinars to what you want to see. Please also get involved in the networking register. It'll be published after this session, and you can view all the posters online under the annual symposium tab. And again, thank you all. Best wishes for the tail end of 2020, and look forward to working, talking, and being with you all in 2021. Bye-bye. Stay safe.